Thank you, sir.
I think
Thank you, sir.
some of the immediate exam goings after this batch of Priya and colleagues. Next batch, I think, is overall the next batch. Is it to go for theory exams?
Sir, me, Bindu and Kayal, sir.
Okay. Right. But presenters are going to be from junior to you, Anish and Aravind. Both of them are 1 year junior to you, isn't it?
Yes.
Okay.
Yes, sir.
Right. Without wasting time, we'll go ahead. Who's going to present first?
I'm sir. I will present, sir.
Anish Kumar. Okay. We are presenting breathing systems. Correct?
Yes, sir.
Okay. Before you start, I will just ask you one question. Why do you want to learn about the breathing systems?
Because we are dealing with breathing system and in our day-to-day life, sir, in anesthesia.
Everyday practice, you are using the breathing system. So you must know about that. What are you going to achieve by knowing about them?
By knowing, we will be able to provide anesthesia efficiently to the patient.
For example, you have only ISTPs or Jackson Rees. Can you anesthetize an adult with that?
No, sir. Only pediatric patient are anesthetized with that because the volume will be less in the tube.
So you must know which system to use for which type of patient. Okay.
Yes.
So that is the main idea, and you must be able to use them effectively.
Okay. Yes, sir.
Okay. So with this introduction, you can go ahead and present your whatever you have prepared, and
Yes,
we will discuss how to learn about that. Okay.
Okay, sir.
You can start.
Breathing system. Breathing system is defined as assembly of components which connects the patient airway to the anesthesia machine by creating an artificial atmosphere um, through which the patient can breathe. It consists of around 7 components, which are the fresh gas entry port or the delivery tube through which the gas are delivered from the machine to the system, and a port which is used to connect the patient airway, a reservoir of gas in form of bag or corrugated tubing is present, an expiratory valve through which the expired gas is vented to the atmosphere, and a carbon dioxide absorber is used, and a corrugated tube for connecting these components, all these flow valves. So the basic requirement of the breathing system is to deliver the gas from the machine to the alveoli in the same concentration as set, and in shortest possible time, so that there should be no leak should be there in delivering the gases, and machine should be able to effectively eliminate the carbon dioxide, so that there should be minimal rebreathing. If there is no elimination of carbon dioxide, there might be hypercarbia, which may lead to respiratory acidosis. And the system should have minimal apparatus in dead space, and should have low resistance. Remaining requirements are the fresh gas economy. It should be cheap, and the heat should be conserved in that, and adequate humidification should be there of the inspired gases, because it might cause dryness of the respiratory tract if there is no humidification. And the apparatus should be lightweight and convenient to use, because the apparatus weight, it might drag the AT tube, and it should be adaptable for both adults and children, And there is provision to decrease the theater pollution. These are other requirements. Coming to history of the breathing system, it was first introduced by Sir Yvonne Whiteside McGill in 1917, and that's why Mapleson A is called McGill's. He's a father of modern anesthesia. And next is Ralph Milton Waters. In 1927, he introduced the Waters to and flow circuit. He introduced it because at the time there was no disposable circuits. All were reusable. So to prevent the infections, he created this water stone flow circuit. And next is Thomas Philip IS in 1939. Created the IS TPs for a pediatric patient, but with that he was not able to control the ventilation, amount of ventilation. Then in 1952, Gordon Jackson Rees, he extended with the corrugated tube, and he was able to ventilate able to control the ventilation with this. And in 1954, the revolution of Mapleson circuit came. Then coming to the classification of breathing system, the classification is mainly based on the function and the equipment. Based on the function, classified by Drips, Random, and Eckenhoff. They classified the breathing system into insufflation, open, semi-open, semi-closed, and closed system. And there's Moyes, who also classified as open, semi-open, semi-closed, and closed. And Collins, he also classified as semi-open, open, semi-open, semi-closed, and closed. Then Adriani, he also classified as open, vaporization, insufflation, semi-closed, and closed. But the Mapleson circuit was confused between semi-open, semi-closed. So Conway classified as in more detail by breathing system without CO2 absorption and breathing system with CO2 absorption. So in breathing system with CO2 absorption, there is unidirectional flow and bidirectional flow. In unidirectional flow, there is a non-breathing system, and the bidirectional flow, it is classified more as afferent reservoir system, enclosed afferent reservoir system, efferent reservoir system, and combined system. And the afferent reservoir system mainly combines of Mapleson A, B, C, because if the reservoir bag is present in the afferent limb, which gives fresh gas flow, it considers afferent reservoir system. If the reservoir bag is present in the efferent limb, which carries the expired gas, it is efferent reservoir system. It mainly comprises of Mapleson D, E, and F. And the enclosed afferent reservoir system is a modification of Mapleson A. It was introduced by Millers. It has a better elimination of alveolar gases there. And then coming back to the detail about open system, semi-open, and semi-closed and closed. Open system in which anesthetic gases are delivered directly into patient's airway. Atmosphere air acts as a diluent, and the patient's airway has access to atmosphere during inspiration and expiration. There is no reservoir. There is no CO2 neutralization. No unidirectional valves are there. Mainly examples are nasal cannula and an open ether mask held away from the patient's face. These are open system. Semi-open, the patient respiratory system is open to atmosphere during inspiration and expiration, and through reservoir that is open to the atmosphere. This reservoir is included in the semi-open. atmospheric air either carries or dilutes the anesthetic gases. A gas reservoir is present. Here also there is no neutralization of CO2, no unidirectional flows. The main examples are open ether mass, which is held in close proximity to the face, and ISTPs with no expirated limb. Expirated limb capacity is less than the tidal volume of the patient, where air dilution occurs. If the expirated limb is short, there might be air entrapment may be there. But if the expirated limb is too long, patient might rebreathe. So rebreathe is semi-open. And coming to semi-closed, the patient respiratory system is completely close to the atmosphere on inspiration, but partly or fully is open to the atmosphere on exhalation. So before semi-open, it was partly open to both inspiration and expiration. Here it is completely closed atmosphere on inspiration and is partly or fully open to atmosphere on expiration. The reservoir is not open to atmosphere. Rebreathing may or may not be present in the semi-closed. All Mapleson circuit come under the semi-closed, but there might be a debate between semi-open and semi-closed. Then water to and fro system also comes under semi-closed. Then comes as closed system. Closed system is there is no access to atmospheric either on inspiration or expiration. There is no escape of anesthetic gases. Rebreathing is complete. Reservoir is present. CO2 absorber is present. There is a unidirectional flow. This all comprise of the unit flow system. If the circle system with the APL valve is closed completely, it comes in a closed system. I must point that if circle system with the APL valve open, it comes under semi-closed. Then coming to the Mapleson classification, the Mapleson classification is mainly based upon the four components like location of the fresh gas flow inlet and the expiratory valve location and the reservoir and the corrugated tubing. These four may classify. With fresh near the it is in remaining all the Maple circuits, the fresh gas flow is away near the patient. Only in Maples near the fresh gas flow is near the bag. Valve location is near the patient in the systems and the valve location is near the patient. The this is it's a Miguel and last circuit. So coming to Mapleson, the location of the fresh gas flow inlet is near the patient. The valve location classic example is here. Mapleson B it's not in use. Mapleson the fresh gas flow inlet is near the patient. The expiratory valve in AM D and A for applications of Mapleson D, in which Mapleson E there's a ISD in which the reservoir bag is absent, and it's a F in which the exit absent. That's then
your audio is breaking.
Mapleson circuits. Mapleson bag acts as a wire for it's a it respiration and depth of anesthesia. It controls it has control of ventilation, and it prevents barotrauma. It also helps in nebulization of drugs. In a ambu bag, in a reservoir bag, the maximum pressure developed. The maximum pressure is developed when the reservoir bag is distended to 4 times the volume of the bag. In case of the bag is distended to 4 times the volume of the bag, it might reach its maximum pressure. For bags greater than 1.5 liter bag, the pressure 60 centimeter H2O. In corrugated tubing, the corrugated tubing helps in increased flexibility, and it produces a turbulent flow. The turbulent flow helps in mixing of the gases. The materials mainly used in corrugated tubes are rubber. Rubber was used before. Rubber was used before because it was opaque and is heavy. It might drag a tube, and there is a wastage of ventilation during due to expansion and absorption. So rubber is not used nowadays, but it is a reusable one. So we can use rubber, but it's not used nowadays. Then the silicone. Silicone is also a reusable one, but it is very heavy, so it might drag the ET tube. So the most commonly used is a plastic one. The plastic is transparent and it's a lightweight one, and it does not drag the ET tube that much because it's lightweight, and it has a lower compliance so that it does not absorb or expand during ventilation. So there is no wastage of ventilation. Coming to about Mapleson A, the Mapleson A circuit is 110 centimeter long length, and the volume is 500 ml. That is, it is able to compensate around 1 tidal volume. The fresh gas flow entry for spontaneous ventilation is 1 minute volume. That is, it is for spontaneous ventilation, Mapleson circuit is best. So coming to functional analysis of Mapleson A, during inspiration, from the fresh gas flow inlet, the gas goes to the patient, and during expiration, the gas comes out, and it gets accumulated in the reservoir bag as well as it goes out to the APL valve. And during the expiratory pass, the next only some of the expired gas goes inside. Remaining the fresh gas only goes inside. So Mapleson A is good for spontaneous ventilation, but for controlled ventilation, during inspiration, the valve opens and some of the fresh gas goes out, but during expiration, all the expired gas goes to the reservoir bag. So during the next inspiration, the expired gas goes to the patient again. So there is a rebreathing present in this controlled ventilation in Mapleson A. So it's not much used for controlled ventilation. This Mapleson circuit is not much used for control ventilation. It's only used for spontaneous ventilation. The Mapleson D, it is ideal for control ventilation because during spontaneous ventilation, during inspiration, the fresh gas flow enters the patient's airway, and during expiration, the fresh gas flow gets accumulated in the reservoir bag, and during next inspiration, the expired gas goes to the patient again. So it creates a rebreathing. But in control ventilation, it does not happen like that. The patient expired gas uh, goes out through APL valve during inspiration. So there is a reduced rebreathing in maple D. So this is the this is why Bain circuit is used for this control ventilation is best. Then the IST piece, it has length of 5 centimeter and diameter of 1 centimeter. The corrugated tube has a volume of 150 ml. That's why it can be used for children for 20 kg around. The next is the Mapleson F, that's a Jackson Reese, which is a modification of IST piece, which has in which the only difference is that valve is absent, so there is minimum resistance, and it is also lightweight, so it doesn't drag that much. Then coming to the coaxial circuits, coaxial means a tube within a tube. There are two circuits, lag circuit and the Bain circuit. Lag circuit was found in 1971. The lag circuit, the inspiration is through the outer tube, and expiration is through the inner tube. So during expiration, it creates more resistance since it is a very narrow tube. So it's not used that much. But Bain circuit is opposite, in which the inspired gas goes through the inner narrow tube, and the expired gas goes through the outer tube. So there is no much resistance compared to lag circuit. So it's always preferred over lag circuit. It has an advantage, is it's very long. So the anesthetist can stand away from the patient, and there is warming and humidification of the inspired gas. And there is also scavenging of the exhaled gas over there. The main hazard in the Bain circuit is if the inner tube is broken, the apparatus dead space might increase, and it might cause hypercarbia and respiratory acidosis. So there are two tests done to test the integrity of the inner tube. There is a Fox Crompton Smith test and Pethick test. When the Pethick test has a disadvantage in which that if the inner tube is broken in the distal part of the inner tube is broken in the distal part, it cannot it cannot not this one Pethick test, but Fox Crompton Smith used effectively. So in general, for spontaneous ventilation, A is best, followed by um, so the principal for positioning of difference is should always be there between the patient and for intellect. Always be between and the canvas. So coming to the canister, the canister ml gram. So each gram absorb 26 liters for 2. So beyond 30 hours, the canister lime and it consists of calcium chloride. The main disadvantage of soda is that there is compound A which is created toxic flats. than 2 hours. It's here with carbon monoxide. It's my Monday morning sickness, and the indicate used in soda lime is ethyl violet, which converts the white to purple. If the indicator is mimosa red, it converts red to white, and if it is Clayton yellow, it converts white to yellow. Those are the indicators used in soda lime. Apart from that, that's all, sir.
Okay, very good. For a first time presenter, you have done a very good job. But for writing a theory answer, it is a commonly repeated question in theory exams. So
Yes, sir.
you have to make it more concise. The elaborate description of soda lime and other things is not required when they are asking about the PV. Okay? And with regard to the water to and fro canister,
Yes, sir.
what is the purpose you said we introduced it?
Purpose it is to observe the CO2, sir. So that there is no repeating of.
How he got the idea of absorbing the CO2 and reusing the exhaled gases back?
It was during the water's to and fro circuit. There is a
Can anyone, Ranjani or Bindu, Arvind, can you say why Waters introduced the to and fro canister? What made him think of absorbing the carbon dioxide from the expired air? Because once you remove the carbon dioxide, it becomes as good as a fresh gas.
yes, sir.
So, what was the necessity for him to reuse the expired gases by removing the carbon dioxide using soda lime?
Okay, for cost, reduce the cost consumption of anesthetic gases.
Not cost consumption. Any other gas we used along with this?
Cyclopropane.
Cyclopropane, yes. We used cyclopropane, which was very, very expensive in those days. Okay? But it was a very potent inhalation anesthetic agent. So it cannot be, you could not use it in spontaneous ventilation where it is the expired gases will be expelled out.
Yes,
So
sir.
he thought of a method of reusing the expired air where some amount of trace amount of cyclopropane also will be there and carbon dioxide can be removed. That is the main purpose for introducing the to and fro canister. And with regard to the Mapleson A, which you said is ideal for spontaneous ventilation.
Yes, sir.
Supposing there is no closed circuit or other methods or breathing systems to do a controlled ventilation, is it possible to do controlled ventilation using Mapleson A itself?
Maybe with low flow.
Low flow. Mapleson A, which is a single corrugated tube with an expiratory valve close to the patient and the reservoir away from the patient at the machine end.
Yes, sir.
Okay, any breathing circuit has a patient end and a machine end. So the two components of any breathing system, one is the expiratory valve, other is the reservoir tank. So
Yes,
where
sir.
they are positioned is very important to decide what will be the usage of the gases as well as the apparatus dead space. Yeah?
Yes, sir.
So in case you don't have a control ventilation circuit like your Mapleson B or your circuit system, you are going
Yes.
to a very small nursing home where they use a very old boiled cadet machine which has only a Meckel circuit or a Mapleson A circuit, and they want to do an laparotomy where they require relaxation to do have a good access. And the surgeon requests you that you do good relaxation. In that case, you have to paralyze and ventilate the patient.
Yes, sir.
So, what modifications have to be done to the Mapleson A system in case you want to use that for control ventilation? So what they described, as you rightly said, if you use it for control ventilation over a period of time, gradually patient will be rebreathing
Breathing.
the expired air and go in for accumulation of carbon dioxide in his body and develop respiratory acidosis and the consequences of that. So in order to eliminate that, what they say is you have to use a 3-liter reservoir bag and you have to keep the valve partially open and have a minute ventilation which is 2 times or even 3 times the fresh gas flow, provide for negative, spontaneous ventilation. So if you do that, then you can wash out the carbon dioxide. But even that can be maximum for an hour or two. Beyond that, again, CO2 ventilation. So these are the few things that you have to remember. So otherwise, the description all was very good. So I'll just show some slides for you to understand and have a visual